All right. I think I'm live right now. Um, Thank you very much for coming to the show. I saw there were a few comments already. I don't know if you're still here, but thank you for stopping by. Um, and I guess because this is a really scheduled live stream, and this is my very first live stream on my channel, so I don't expect a lot of you know what's going on. That's okay, and I hope this will be recorded and I'll be able to play back uh, on uh, the content later time. uh, Sorry about the a little bit itchiness of my voice. All right. So, uh, the topic that I want to have a little bit discussion today is on the CDC ACIP meeting. They just had it. They just wrapped it up a couple hours ago, and the final recommendation that the committee voted is that they recommend the new bivalent vaccine for the Pfizer one for 12 and up, and for as long as you are more than 2 months after your previous dose, either the primary series or a booster. Okay, and for Moderna, this same rule applies: the more than 2 months or of your last primary series or your last booster dose, but that's for 18 and up. So there's a little bit small difference between the two vaccines in terms of the age lower limit. Now, these language are exactly aligned with the FDA authorization language. Now, very interestingly, during the meeting, in a one of the member asked, "Do we have to put that 2 month in there? At least 2 month?" The CDC representative basically answered that there would be legal repercussion or some type of a legality if the CDC put out a different language than the FDA authorized language in terms of the time frame. So that is something quite unexpected. A lot of the committee member did question about this 2 month thing. The CDC did clear up saying that, well, we're not saying that you should be getting booster every 2 months, but it's just that, if you had it for 2 months, you could get it. Okay, and they basically quoted a lot of the number during the meeting, saying that there's very few people had it in the last 2 months. So most people had it more than 2 months, and that would be okay. Right. So the main topic that I really want to touch upon in tonight's live stream, okay, instead of making a recorded video, is like the title said. Well, if you are infected, or if you have boosted, you're infected, what should you do? Right? There's a lot of those people around, including Mr. President, First Lady, Fauci. They were all boosted 4 doses, and they had a very recent breakthrough infection. And what does the guideline now tell them to do? Including a lot of my colleagues were in that same boat. If you've been following the channel, you may remember in early June, I went to Utah, and half of my colleagues that went with me, we all had 3 doses, and half of them got breakthrough infections, presumably Omicron, maybe BA5. So what are they going to do? All right. So that is a very tricky questions. And in terms of solid the official language in the recommendation, there's really nothing talking about, hey, prior infections and all these. So, and a lot of the discussion were saying that we don't want to put it in there because we want the language to be a little bit more simplified, more easy to understand. So what happened is ended up, well, a lot of the responsibility is going to go to the primary care physicians or provider. Okay, so and someone like Mr. President, First Lady Fauci, I'm sure they have their own determinations about what to do with the booster. But if you are like them, okay, you are in the same boat. You are boosted. You get breakthrough infections in the last 2 months. Okay, what to do? Is it going to help you, or how much helpful is it going to bring it to you? So here I'm going to show you just a couple slides. They got a lot of data presented in the whole meeting, and I'm going to just show you a little bit. All right, so this is first time I'm using this software. I think it's working okay. So you're looking at the data that was presented during the meeting, and this is from Moderna. Okay, so from Moderna. Now, just some definitions in terms of what are these vaccines. The mRNA 1273 is the original strain booster, the one that they have been giving us for this whole time. And the 1273.214, okay, this is the BA1 Omicron bivalent booster. Now, notice that a lot of these data are not the BA45. Okay, BA45, remember, there's no human data like I covered in my previous various videos. And the only human data that is relevant with, linked to the BA Omicron bivalent booster is the BA1. Now, if some of you are watching this later, or from UK, or from even Canada, okay, if you're from Canada, from UK, from different parts of Europe, you are likely to, some of you are already know that you'll be getting the BA1 Omicron bivalent, okay? Other countries in those areas, it's likely to be getting the BA1, so which is different than what we are getting here in the US. So this set of data could be a little bit more relevant to you. Okay, so let's look at this graph. Now, this graph described the fourth dose, aka the second booster, with the BA.1 Omicron bivalent booster versus someone getting just the original, original 1273 boost as a fourth dose booster, and against the Omicron BA45 in a neutralization assay. So this is a in vitro assay. Okay, so I want to touch upon these two graphs. Now, this Moderna, actually, I think they did a little bit better job today than Pfizer when they were presenting their data. They actually segregated the effect for someone that had no prior infections, meaning just 3 doses, no infection. Perhaps I would be in that group. I don't know, because I'm sure I was exposed. I just never had a symptomatic infection. And versus someone that had 3 doses and a prior infection. Now, this prior infection, unfortunately, it's a little bit difficult to find out if that was an alpha, delta, or omicron. Now, there are some studies saying that there may be some differences in terms of what strain you got infected will have different immune response. So regardless, let's just treat it as a little bit more straightforward way of looking. Someone got 3 doses, no infections, versus someone got 3 doses, had infections. Okay, now both of them are getting the 4th dose. Okay, both of them are getting the 4th dose. And the light color one bar is those that are the original version, original strain booster, and the dark blue one is the BA1 Omicron bivalent vaccine. So what I want to point it out is here, look at in this, I'm trying to put my mouse over there, trying to highlight some of the area here. Now, this is a graph. This is 2 bar that is comparing someone had no infection but boosted versus with the 4th dose and not with the 4th dose. So there is a clear increase in the antibody titer. Okay, that is decent, from 140 to 490. Now, notice that with someone that had infections, right? We're comparing this 2 graph with these 2 graphs. So someone had 3 doses, had a prior infection, had an antibody titer 609 against BA45. All right. This level, have you noticed that it is higher than someone that without prior infection? All right. So what it means is that, well, if you had no infection, now at this point, it's hard to know if you have ever had no infection at this point. You've got three doses, no infection, and when you receive the new fourth dose based on the based on the original strain, your booster level is gonna be lower than as is someone that had 3 doses and had an infection. So it shows that the hybrid immunity is good. It's really standing up. Okay. So this gives you some idea of, what would it do to someone that had already had a infections or breakthrough infections? What does that do to the antibody level? All right. Now, what if they're getting the new bivalent vaccines? Here is the blue graph bivalent vaccines. All right, once they get that bivalent vaccine, it get a bigger boost than getting the original boost, which is this title says higher neutralizing antibody titers. All right. Now it makes sense. You're giving something that is more specific to Omicron, and when it wanted to fight the Omicron BA5, it's gonna be a little bit better. So it's totally reasonable to to expect that value. And again, if you are having another boost after infection, you get the highest 2,200 337. All right. Now, again, I want to compare is that someone with 4 dose and someone with 3 dose and an infection. All right. So what you see is that it's comparable. Again, 720 versus 727. So at this, and based on this, now this is very limited data. Now I cannot say for everybody, but at least based on the Omicron data that Moderna is presenting during the meeting, it tells you that the neutralization antibody, from someone that had a breakthrough infection, fairly recent, presumably, basically it's similar to someone to get a new booster. All right. So, what that's why this is some of the things that were not so much touch up on uh, in terms in the recommendations that are currently listed. Right? They didn't tell you very explicitly that when you should be getting the fourth dose after all these breakthrough. Like someone could have 2 breakthrough. We don't know that. So that is something that we're quite confusing, kind of left off from the meeting. The one of the main thing that they argue that, well, someone had infection, you should still go get the fourth dose or fifth dose that is now the bivalent. The reason is that, well, they see that the high increase in the antibody level is going to be beneficial. So that is their argument. It's going to be beneficial. And almost the message is like the higher, the better. The higher you have, it will take longer for it to wane down, go down below to a level. So it is, we all recognize that it's going to wane the antibody levels regardless of how many dose or how many boosters you're going to have. So that leads to another question is that, well, that may be available very soon, as early as next week. And as soon as it's rolled out, there's going to be a push for people to go get it, go get it. Now, as if it's gonna wane in 3 months, 4 months, 6 months, is it gonna last for the winter? There were some of the committee member were asking that question. Surprisingly, the CDC gave out some unexpected data based on modeling. Yes, that's modeling, and the main argument from them, let me show you this graph, saying that, well, we should give it out in September. We should not be waiting for human data coming in 2 months or even December, because because of some one of the couple reasons. This reason is based on this modeling, and they said, now this is very beyond me in terms of understanding how they get to this data, but their message is that by giving out this new bivalent vaccine earlier, it can help reduce more than 20% reduction in the hospitalization and have more than 15% reduction in death. All right. So, and that is some of the message. And especially this is if it's better to just for everyone. All right. Not just the vulnerable populations, but for everyone. And well, let me trace back. Yeah, this is the exact number. All right. So in September versus in November, there could be more could prevent more hospitalization by a number 137,000. Now this is a number that is based on the modeling, and I have that's beyond my expertise to understand this model. I have to admit that. So I just have to take it for granted, and that's the additional hospitalization that can prevent by giving the vaccine 2 months earlier, and there's the additional deaths that can prevent by giving it earlier. Okay, now so by definition, and they probably use this type of a data and also extrapolated that because we're preventing so many hospitalization, we're preventing so many deaths, okay, by giving it out early, we can save money. Okay, we can save money in the healthcare system. So you're not, going to hospital, you're not, getting hospital care. So that is a direct cost saving. That is their argument, part of their argument. Now, other arguments including that, well, it's okay to not have human data at this point because we've been doing that for the flu vaccine for years and years and years. Now, for those of you that are not familiar with flu vaccine is that every year there's a prediction of the new strain for the upcoming year. They don't do clinical trial every year to test in human, and basically they just approve that. The rationale is that that is a variations of an old product, and there is also established correlations between antibody levels in preclinical studies and correlate that to the protections. Now, this is a bigger topic, and certainly we can talk about it maybe in this upcoming weekend video, and just can we really apply the same rule of how we approve flu vaccines to approving this COVID mRNA vaccines, okay? So that's something worth for a little bit further discussion later on. That's how I feel about that. Now, in terms of Pfizer, Pfizer really, they didn't do a lot of good presentations, frankly, in their presentation. The only main thing that they pointed out that were a little bit different compared to Moderna is that they made an argument for bivalent. Okay, why give bivalent of an original strain plus an Omicron strain, and versus just giving a monovalent of Omicron? So the biggest argument is that the giving a monovalent Omicron is not going to give the broad coverage of antibodies, and this show, yes, it is shown in mice, unfortunately. So that is some of the data they have. It is not ideal. It is not ideal, and no, we're not going to go into the very much debate there. Another thing I want to point out that that is something a lot of people are concerned, including me, is what about young male, right? Maybe someone like me. Okay, I can tell you I'm less than 40 years old. I had 3 doses of Moderna. Perhaps I had asymptomatic infections back in June, which I couldn't detect it out. Okay, but I felt fine. All right, so I was exposed. Okay. Um, so someone like me, you know, myocarditis is a valid concern, particularly with Moderna. And some of you may be following with a new study coming out that just came out a couple of days ago, maybe last week, regarding the new findings of myocarditis after 2 doses of Moderna being quite high. Okay, we can again go over that a little bit in our next talk. But someone like me, like, you know, do we know what is the risk? Do we know the small incremental benefit? That is something no one have an answer exactly. So sadly, I and frankly, someone like me, if I go to ask my primary care provider, uh, they wouldn't be able to give me an answer because there's no literature, no real guidelines on that part. Now I'm closer to the 40 years old. Perhaps I'm okay. Okay, perhaps my risk for myocarditis is not that high. But for some college students, 20, 22, maybe young, healthy, they perhaps got 3 doses because of maybe their university maybe mandated that. Okay, they got 3 doses. They may have gotten the some infection, Omicron breakthrough over the summer. And what do they do? What should they do? That is another question that is would be solely relying on their primary care provider. And uh, again, that's a very tough question to answer, I believe, because certainly there, when we are talking about evidence-based medicine, there's not a lot of literature there to provide a good guideline. And the only thing is that someone that absolutely want to prevent infection at all cost, that's something that you should consider, definitely. And for the elderly with or immunocompromised, these are something that you should consider. And now, in terms of immunocompromised patients, there's about 3% of those in the country, in the US. um, Trials are going on, but there's nothing really presented during this meeting. Presumably, it's going to help. How much, we don't know. So how much help, that is hard to say. Now, I've been focusing on this screen for a while. Then you wonder what's going on here. I want to come back to this a little bit. And here is the Pfizer, what they've done in terms of investigating uh, similar vaccines. So they, at some point, they investigated a beta monovalent in a younger population, 18 to 55, and Omicron BA1 monovalent, again, in the younger populations, and later on in the older populations. And in terms of the bivalent BA4/5, it is still going on with the clinical trial. So all of the human data that Pfizer currently has is only uh, based on 18 to 55, 18 to older, 18 above. But their recommendations or their authorization is from 12 to 17 as well. So keep that in mind. There's very little to reference what would happen in terms even the immunogenicity or the effect that can affect its antibody level. All right. So that is questions. And in terms of Moderna, they did have data that are a little bit closely matched to the age, and I couldn't find that exact slide at the moment, but they all of their human data were right here, 18 to 64 and 65 and above. So this is very similar to what I've just went over for Moderna in terms of someone had 3 doses, had a breakthrough, their antibody titer level are pretty much similar, all right, to someone that are getting 4 doses, okay, to 4 doses, regardless of uh, it is a original booster or a BA1 bivalent booster. All right. So let me take a small break and let's look at some of the comments that you guys are putting down. Thank you very much. USMC 720 72409. Uh, Thank you very much for coming. You're best. You're the best. Okay. So let me skim through some of um, the comments here. I say that. Do you think they will realize that it's a jab, that it's infections, those? Try to find some question that I can answer with get. Well, why would you get yourself injected with COVID from Anthony? There are many reasons for people to get vaccine, and there are many reasons for people to not get the vaccines. And certainly, some of the reasons are not. You cannot decide a lot of things when you're working in the out there, and there are many mandates, and there are many organization mandates, and the choice is having bread or taking the shot, right? So we all know that. First live broadcast. Yes, thank you. This is my very first live broadcast on YouTube after uh, 2 years, about more than 2 years active being on YouTube. So this is a Keith asked a very good question. How was it Omicron did not derive from either Alpha or Delta variants that were circulating at the time, but directly from the wild type that is circulating from 2020? Now we believe the Omicron, based on some of the sequencing data, they were from South Africa, originated from South Africa, and uh, yeah, this is we don't have a good answer that was all the way from that, but they do carry the same D614G mutation, for all of them, for Alpha, Delta, and Omicrons and Beta. So that is something that was inherently there, and so there were other study that I presented many months ago, but when back in December when we first identified Omicron. The theory, one of the theory was that it could be developing from immunocompromised patients, right? And when they have multiple infections, perhaps with different strains, or even with another type of coronavirus that were like more for common cold, and there's some cross, you know, reactions between different strains, and came up with this new variant. So there's some of those theory there. Okay. I couldn't find where was the comment. Someone asked me what am I referencing here? Okay, now these slides I downloaded from the CDC ACIP website. Okay, it is today's September 1st meeting. Okay, they put up all of the slides. I didn't make up any of those slides. You can always go up and Google it out, and I can always put down a link after this streaming in the description box so that you can go reference it. All right. I see someone have reactions, have long reactions, and I'm sorry to hear that. And all right. Now, earlier on, there was a questions about you cannot get this bivalent vaccine if you have not gotten primary series. Is that true? Yes, that's true. That was not recommended. So the recommendation right now is if you had no vaccine at all, okay, and you decided now you want to get vaccinated, you have to get the 2 doses first and then wait at least 2 months to get the bivalent vaccine. So if you get it right now, it's going to be almost near the end of the year to get this one. So one of the reason, so it's because there's no data really to back up what if you just get this one. There's no data at all, and uh, we don't know the effectiveness. We don't know the side effect if you just get this one. Presumably, there may be less side effect, being that this is a smaller dose, uh, compared to the primary series. Okay. Yeah, modeling it's something that is beyond me. Okay, someone in the audience, maybe you can help me with that, with modeling, if you are an expert in that. Okay. All right, so here it is a comment. The test data on mice apparently adequate for preparing this new bivalent inocular jab for mass rollout for worldwide human trial. Same lab and mice that manufactured Omicron. I try to see if I can understand what exactly. Now, so the argument from the CDC side is that, again, it's model of flu vaccine. All right, so flu vaccine, we don't need human data. In COVID-19 vaccine, we've had a lot of the experience based on their opinion. Now the time wise is not a lot, right? About 2.5 years, but there's because we've given so many doses, right? So we know a lot, and that's why we can now just rely on the mouse data and do it. I think the focus were the presentation itself, because there were just mouse data or very small human clinical trial. There were not a lot of this presentation data on side effect, mostly just on some of the common side effects, like the reactions to the like fevers, local reactions, and all these, etc., etc. So but the committee member, I think they've done a pretty decent job. I have to be just fair. A lot of them did questions the risk of myocarditis for these younger populations, and what should they really do. Okay, and unfortunately, there was no answer really that was given at the during the meeting. Okay. Everyone's best guess. I think it is at some point right now. It is a best guess. As a lot of those modeling are assuming things are happening in the way that was modeled into the situations. All right. Doesn't stop infection. Um, yes, there was no discussions on stopping infections, and the discussions were really focused on the reductions of hospitalizations and death. And how much this would help in terms of that. All right. So there's a lot of comments. I have a little bit. Thank you for Hank. That is for me to be here the first live podcast. I've never really anticipated my first casting is going to be on this topic, but if you've been following long enough, I'm actively planning to stream about different content on this channel, and perhaps even record it as audio later on. So you can see all the setup that I've been getting. And I do have to shout out here, thank you for Dr. Bean, if those that are, or Dr. Mo Bean, he did give me a lot of guidance in terms of getting into this streaming uh, format on YouTube, and he's the king of stream. All right. Okay. So, so some of the topics that I am not exactly totally familiar, especially someone in this, I do want to bring it up. Leaky vaccine used in the disease in chicken in 1970s. But there's a little bit historical background here. I'm not too familiar with it, but I do want to look it up a little bit and have a little talk later on. Thank you very much for bringing up that. All right. Yes, I thank you for someone bringing it up. If I'm on other platforms, currently I'm not on any other platforms. I certainly managing additional platforms. It's quite demanding in a sense to in addition to my full-time job at the university in the daytime. So, but I will consider if there is a need for that, and I'm aware that um, there are certain language that I need to be very careful on YouTube, and not to gear into certain directions that may violate some of the community rule here on YouTube. All right. So I think this is long enough. 37 minutes, and so that's why so just to wrap up this whole casting message is that if you had infection, if a breakthrough, you have 3 doses. What are you going to do with the 4th dose? Quick answer is talk to your physicians. Now, I know this is not a good answer, but based on some of the antibody titer levels, if you had a recent breakthrough infections, your antibody titer levels are pretty high, as high as someone that is going to get their 4th dose without any infections. That is something we kind of pretty sure at this point, based on some human data. Okay, based on some human data. All right, is it gonna be exactly the same as what Moderna presented? No. For the U.S. population, no, because we're getting BA.4/5, and for it may be a little bit similar. You can expect similar things for countries that are getting the BA.1 bivalent. All right, so that's what I want to wrap up. For tonight, and thank you very much for coming to this first ever streaming show here on my channel. I'm glad that I have an opportunity to interact with you all in this live fashion. So, I'll take a look of all of this comment and try to address as much as possible in my next video, a recorded one, like my usual Sunday video. So that is all for tonight. And again, thank you very much. And I hope to see you again in my next video. And meanwhile, do the best to protect yourself, protect your family. Okay, take care. Bye.